today I'm going to talk about a practical approach to the poison child. So management of children who present with poisoning is often challenging, and this is due to several reasons. Compared to adults who come most of the time with a clear history and with a known history of what the ingested substances are, children often present with an unknown history of poisoning, and the poisoning event is often unwitnessed and it's unintentional. Therefore, the history is often vague. And also, determining the ingestion time is difficult because we don't know what children have ingested and the time they have ingested. And for the same reason, determining the ingested dose, thereby predicting the risk of further toxicity, is often difficult in children. And it's also important to know that the circumstance of poisoning also usually change with the age. Most of the younger children present with accidental, whereas as the children grow up, they present with either accidental or non-accidental poisoning. And also with the body composition, the weight and the fat distribution of children, the toxicokinetics of this poison substance also change. So we know the behavior of toxin may not be the same in each and every child compared to an adult with the same body size. And also certain ingestions may have a safeguarding concern. For example, a very young child coming with suspicious poisoning. And also because of the body weight and the body surface area reduction, in some cases, a few pills, even one pill or a couple of pills, can kill young infants with certain poisons. Therefore, we have to do the risk assessment based on the worst case scenario, where we anticipate symptoms or kind of a complicated course following the poisoning event. So let's look at the global epidemiology. So poisoning is still a common problem everywhere in the world, and it accounts for nearly 45,000 deaths every year in the world. It's caused, this is the data due to accidental poisoning, and there are a number of cases, like a number of children and teenagers who die following non-accidental poisoning as well. Therefore, these continue to be a significant cause of morbidity and mortality, according to the WHO, the recent most report published in 2008. If you look at the Sri Lankan context, kerosene oil is by far the most common poison. 2 decades ago, as well as currently, in both urban as well as in rural Sri Lanka, all the contribution made by that is on the decreasing trend because of the infrequent use of kerosene oil. And now we see a rising trend for poisoning with pharmaceutical agents as well as sanitary products because of their increased use. And plants and pesticides are still seen, but they are more common in rural regions compared to urban regions. Overall, poisoning in the pediatric age group is associated with lower mortality, which ranges from 0.4% to 0.7%. And also, if you look at the data, there have been notable reductions observed over time with regard to practice of harmful remedies by parents because of the increased public awareness as well as the education level of parents. So why children are susceptible to poisoning? There are two peaks of poisoning. One group is the younger children, toddlers, like children who are less than 4 or 5 years of age, and they ingest the poison mostly unintentionally within home, and most of these events are minimally toxic. And the incidence of these poisonings are largely determined by the availability of the poison within the household. And the predisposing factor is mostly the children's exploratory inquisitive behavior and the lack of sense of danger, leading to unknowingly experimenting with these substances. Whereas in adults, you can see both intentionally as well as unintentionally. And this occurs mostly as part of deliberate self-harm, which is quite common in the teenage age group. And also there are like a fraction of teenagers who tend to experiment with illicit substances and recreational drugs and thereby getting poisoned. Let's look at the anatomical and physiological considerations when we talk about children. Why? So the significant differences in terms of the effect of the toxin. So in children, as children grow up, the volume of distribution increases. This means like the drugs with a larger volume of distribution, they develop symptoms late in the older child. Indirectly, this means that an infant is likely to develop early symptoms as well as early toxicity following ingestion of the same dose. And the body surface area, the smaller children have a bigger body surface area. This can impact especially the topical application toxicities, for example, methyl salicylate. So the younger children can get more toxicity because they have less body water and larger body surface area. And skin, for the same reasons, especially the neonates who have a thinner skin compared to other children. Topical agents like methyl salicylate, dermal absorption is quicker as well as more, resulting in higher toxicity. And airway problems are more with children with smaller bronchi, smaller bronchial trees. So the toxins which can cause bronchoconstriction and secretions, for example, organophosphates, are seen more commonly in younger children. And ventilation, so younger children have a greater minute volume. Because of that, aerosolized toxins, inhalational toxins can have a higher toxicity in young children. And hepatic and renal, because they develop until a certain age, when they have immature renal functions or hepatic functions, eliminations can be delayed when the poisons are excreted through that pathway, and thereby we can see a higher toxicity. And breastfeeding, some of the toxins or some of the poisons can be secreted, for example, aspirin, cocaine, lithium. Therefore, even though child not have taken the poison, child can be indirectly poisoned because of the breastfeeding in some cases. And also, there are certain few poisons which we need to know. Even 1 or 2 pills can kill the child, especially a young infant. And these poisons include few categories: sodium channel blockers. So sodium channel blockers include tricyclic antidepressants and sodium channel blocking antiarrhythmics, beta blockers, and chloroquine. So they have very high toxicity even if you take 1 or 2 pills. And this is similarly seen with calcium channel blockers, which can cause severe, profound bradycardia and hypotension. So even if the child takes 1 tablet, it can be quite significant, and we need to monitor and manage very carefully in children who are presenting following ingestions of these tablets. And also, opioids can result in respiratory arrest. Theophylline can result in cardiac arrhythmias. Amphetamines can cause severe cardiac arrhythmias. Sulfonylureas can cause profound hypoglycemia. Organophosphates can result in cholinergic toxidrome, and oleander can cause cardiac arrhythmia. So all of these agents, whether they are pills or not, even a small quantity can result in deadly consequences in the child. So what's the general approach we need to take in managing children? So for the same reasons I mentioned earlier, we have to manage considering the worst case scenario. So assume the time of ingestion as the latest time possible. And assume all agents that are unaccounted for missing were ingested. And spillage. So sometimes parents might say, they saw some of the syrups were spilled everywhere, but it's very difficult. So you have to account for them, right? And then when more than one child is involved, when 2 children together ingest a certain poison, then we have to assume that both children have ingested all the poisons. And also, if you are not sure, it's always good to consult the Poison Information Center. So it's very, very important to do an appropriate history taking and an appropriate physical examination in managing children with poisoning. So the main part of history taking includes doing a proper risk assessment. There are 5 components in this risk assessment. So first of all, we need to decide on what the agent is. there are many instances which are very difficult for us to determine what the agent was, because the poisoning event is often unwitnessed. So we can ask from parents or grandparents whether they are on any medication or whether they have had any medication at home stored. And also whether there are any tablets spilled or whether there are any missing tablets. So by that way, we can estimate if a child had ingested the poison or not. Or else if the child had been moving around in the garden, then we can ask whether there had been any poisonous plants grown in their gardens. And also, it's important to determine whether the tablets are standard release or extended release, because the pharmacokinetics can be different and the onset of toxicity are variable depending on whether they are standard release or extended release. And then determining dose, and then determining the time since ingestion. So if it's difficult to determine the time correctly, then always take the latest time as possible. And then assess the current clinical status. So see whether what symptoms the child developed following the poisoning event, whether they had vomiting, diarrhea, abdominal pain, and so on. And then look for specific toxidromic features, which I will be talking in a while. And also consider the patient factors. Ask whether they have had any kidney malfunction, liver malfunction, body weight, age considerations, and whether they have had any past medical history, for example, psychiatric comorbidities, and so on, in taking the history. And then physical examination. So do the vital signs assessment. So assessing the blood pressure, pulse rate, temperature, oxygen saturation, and respiratory rate are vital in assessing any child with suspicious poisoning. And also determine the level of consciousness and assess the pupil size, and assess for skin signs, whether there had been profuse sweating or whether dry red skin are present. So these are important assessments in addition to the routine physical examination when examining a child with suspected poisoning. So observations are critical in evaluation of any child with any symptomatic child with poisoning. And they help us a lot to narrow down the differential diagnosis. For example, respiratory rate can be low or high, and depending on that, we can roughly estimate what the poisons were. So if the child's respiratory rate is low, the child is having bradyapnea or having irregular breathing, then we have to suspect agents such as benzodiazepines, opioids. And in contrast, if the child is tachypnic, then we have to suspect agents like stimulants, amphetamines, ecstasy drugs, salicylates, which can cause tachypnea, and toxic alcohol poisonings. And if you consider the heart rate, you can see a tachycardia in stimulant poisonings and anticholinergic poisonings like athena or theophylline, or any like beta agonist poisonings. Whereas bradycardia is seen with beta blockers, calcium channel blockers, digoxin, organophosphates, and so on. And blood pressure can be severely low, like severe hypertension can be seen with agents such as tricyclics, beta blockers, calcium channel blockers. And in contrast, you may see high blood pressure when you ingest stimulants, especially the teenagers who present following ingestion of recreational drugs toxicity. And temperature is also quite helpful. If the child's temperature is high, maybe due to ingestion of agents such as cocaine, ecstasy, or salicylates, whereas hypothermia is seen with ingestion of agents such as barbiturates or alcohol. And consciousness can be low in children who present following opioid ingestions, benzodiazepine ingestions, or antihistamines such as Piriton overdoses, or oral hypoglycemic agent overdoses. And pupil size is also a very it's a very helpful sign. So pupils can be constricted with agents such as organophosphates and opiates, whereas pupils can be dilated with agents such as atropine, athena, tricyclics, and amphetamine. So if the child is having one of these signs, then they are quite useful in narrowing down the differential diagnosis. And we usually follow stepwise management in managing any child with significant poisoning. So first of the priority is given for resuscitation. So if the child's airways are compromised, then before any assessment, we need to secure child's airway. Or if the child's hemodynamics are deranged, then we have to to resuscitate and give inotropes and stabilize blood pressure and pulse rate before doing any other assessments. So after resuscitation, according to standard APLS protocols, then we can do a thorough risk assessment like I presented previously in a previous slide. And then after the resuscitation and risk assessment are over, then the next step would be to offer supportive care. And then we can do relevant investigations, but remember, investigations are not like we don't need to do a whole list of investigations. Most of the time we can do the minimum number of investigations to manage patients. And then decontamination within the window of period, like where the decontamination is likely to be effective. And this can be followed by elimination techniques for poisons which are excreted through elimination techniques. And then there is a place for antidotes for certain poisons. And then finally, the disposition to decide on where the child needs to go, for example, to the ICU or to the ward, or the child can be safely discharged home. So resuscitation is important in certain poisons. So we always follow the ABCDE approach. So airway management is crucial in children present following poisoning, like poisoning with agents such as benzodiazepines or organophosphates or corrosives, which can cause mucosal burns or upper airway burns. And breathing can be compromised with agents, again, such as benzodiazepines or cholinergic agents such as organophosphates, or sometimes breathing can be compromised with aspiration of certain poisons such as liquid hydrocarbons, kerosene oil, and so on. And circulation can be compromised with agents such as calcium channel blockers, beta blockers, and tricyclic antidepressants, which all cause bradycardia and hypotension. And then some children can present with seizures. These seizures can be due to cardiac arrhythmias. These seizures can be due to hypoglycemia. So we need to find out why the child is having seizures. So we sometimes need to find the underlying cause and manage it rather than just managing a seizure with antiepileptics. And blood sugar needs to be checked in all children with impaired consciousness or who are not conscious, and blood sugar needs to be corrected. And it's important to correct hyperthermia as well in the resuscitation stage, because it can be life-threatening, and this can occur in conditions such as serotonin syndrome or sympathomimetic or anticholinergic toxidrome. And I will present what they are in the next slides. And sometimes antidotes are administered in the resuscitation table itself and the children recover. For example, naloxone for opiate poisoning. So if you administer naloxone, they need to be administered then and there. One good example is like we administer naloxone to children of whom the mothers were given pethidine during the normal labor. And so children may have respiratory depression soon after birth. So if you want to give naloxone, then the naloxone has to be given then and there to reverse the respiratory depression. And then the decontamination with activated charcoal. So activated charcoal is like we use it, it's the most frequent agent that we use for decontamination purpose. So it effectively controls enteral and enterohepatic circulation of the poison. The usual dose is 1 gram per kilo, or the 10 times the dose of the poison. And some recommend that mixing with a flavor or ice cream or yogurt increase the compliance. Otherwise, we all know that's very difficult to administer activated charcoal to younger children. And it's very important that the airways are protected before we administer activated charcoal to drowsy children. Otherwise, it can lead to charcoal aspiration and chemical pneumonitis. And sometimes, so the drugs with significant enteroenteral and enterohepatic circulation, it's recommended that we administer multiple dose activated charcoal. And the indications include aspirin, barbiturates, phenobarbital, and theophylline. And activated charcoal is ineffective in heavy metal poisoning such as iron or lithium, and alcohol pesticide poisoning as well. And activated charcoal is generally contraindicated in the presence of bowel obstruction and GI hemorrhages and poisoning with liquid hydrocarbons and unprotected airway, where there is increased risk of aspiration. And gastric lavage, we don't frequently use as we used to do earlier. and it's currently only indicated in life-threatening ingestions that cannot be effectively removed by other means. For example, lithium and iron, which are not absorbed by activated charcoal. So your only early means of removing the poison would be gastric lavage. And it should be carried out only if there is adequate airway protection. So it's generally contraindicated in children who are drowsy or airway at compromise. And lavage is contraindicated in children presenting with corrosive substances because of the risk of chemical damage. And there are a few poison elimination techniques as well. So elimination differs from absorption because when a drug is, so if you consider the pharmacokinetics of the drugs, each poison has 4 phases. First one is the absorption, and the second phase is the metabolism, and the third phase is the elimination, and the fourth phase is the excretion. So this elimination phase, absorption, distribution, metabolism, and elimination. So this plays a role in the elimination stage. So elimination, so agents which help in elimination essentially helps excretion of agents that are metabolized as well as unmetabolized as well, right? So these methods include multiple dose activated charcoal and urine alkalization for substances which are excreted through urine, such as salicylates and phenobarbital, and whole bowel irrigation, and dialysis, and hemoperfusion and hemofiltration. Hemoperfusion differs from hemofiltration in that hemoperfusion uses a cartridge which contains an absorbing agent, usually activated charcoal, and as the fluid or as the plasma moves through the cartilage containing charcoal, effectively gets rid of the poison by absorption, whereas hemofiltration is more or less similar to hemodialysis. So whole bowel irrigation is used in situations where the child had ingested modified release preparations or enteric coated formulations, in which case the poison is likely to stay within the gastrointestinal system for a while, so that these drugs may be staying in the GI tract as well as sometimes may be eliminated through the bile after initial enterohepatic circulation. So in that way, whole bowel irrigation helps in excretion of both the metabolized and unmetabolized poisons. And it also used in special occasions such as body packing. So body packing refers to individuals who ingest drugs or drug packets as a means of transferring these drugs from one place to the other, like for example from one country to other country. So the only means of removing, because they have ingested large amounts of body packets, so one effective way would be to give whole bowel irrigation, and activated charcoal is generally contraindicated in these children, in these teenagers or people. And investigation. So these are the few investigations that we can consider doing based on a case-by-case basis. So if the child is unconscious or drowsy, always consider doing a blood sugar. And if the child has ingested, or we have a doubt about whether the child has ingested cardiotoxic agent, it's always good to do an ECG and then offer cardiac monitoring. And if the child is having vomiting, diarrhea, or if the child has ingested an agent such as sodium channel blocker or a calcium channel blocker or a cardiotoxic drug, it's always good to do electrolytes as well. And you can do blood gases in the unwell child. And if the child has ingested a radioactive substance such as iron containing oral contraceptive pills or lithium, then you can consider doing X-ray abdomen. And urine toxicology we don't use in the emergency departments. Its use is limited, but it may help in places where you have medical legal concerns or safeguarding concerns to prove or disprove a child or a teenager has been given a poison. And then we can consider antidotes, a few antidotes to name, like glucagon for beta blockers, oxygen or hyperbaric oxygen for carbon monoxide, hydroxycobalamin for cyanide poisoning, and then digibind for digoxin or canary poisoning, then famotidine or ethanol for ethynyl glycol poisoning, desferoxamine for iron poisoning, and so on. So as I told, like most of the children who are toddlers, their poisoning events may be trivial. So after a careful risk assessment, if they have minimal or no risk of having further complications, and if you can decide that no further treatment is required, then they can be safely discharged. And the symptomatic children, on a case-by-case basis, can be observed until they are out of danger. And safeguarding concerns. So poisoning events may have safeguarding concerns as well. So always consider and rule out if you have a doubt. And accidental injection is commonly a result of inappropriate or inadequate supervision. So it's always good to talk to them and then provide education, because recurrence is quite common, up to 30% in those who haven't been offered education about prevention. So one good thing we can do is we can refer to public health. For example, we can refer to the local public health midwife who can pay a subsequent home visit and then supervise or advise regarding the home safety to prevent further poisoning. And if the history is inconsistent or stories are not fitting with the developmental capabilities of the child, then they raise serious concerns about safeguarding, which has to be dealt according to the National Child Protection Safeguarding policies. And then poisoning and deliberate self-harm, which is seen in older children, teenagers. And this is quite common, although we don't see. Some children may present to hospital, some may not. So it's very important that if we come across a child with deliberate self-harm, irrespective of how trivial the dose is, they need to be referred to child psychiatry to arrange ongoing support and follow-up. So let's look at a few poisons. So I'll first talk about paracetamol poisoning. So the toxic dose is more than 200 milligrams per kilo over a 24-hour period, or if you consider repeated supra-therapeutic injections, 200 milligrams per kilo over 24-hour period, or 300 milligrams per kilo over 48-hour period. So in the box, the metabolism of paracetamol is shown there. Paracetamol is usually metabolized through the sulfation and glucuronidation. However, in overdose, cytochrome P450 pathway comes into play, resulting in formation of a metabolite called N-acetyl-P-benzoquinoamine, which is toxic. And when you have enough glutathione stores, which means like when you are not malnourished, not an alcoholic, then you have sufficient glutathione stores, and then they reduce this toxic metabolite to non-toxic products. However, if the child is malnourished, or if you have taken a sufficiently large dose to saturate all the glutathione stores, then the accumulated NACU can result in serious liver toxicity as well as nephrotoxicity. So in overdose, it gets the absorption kinetics become quite prolonged, and you can see longer lasting toxic effects in higher toxic doses of paracetamol. So we can what are the markers of early injury? So liver function tests are not good enough to identify early injury. So the two recommended ones are the determination of the dose. For example, if the child presents with more than 200 milligrams per kg single overdose, then that's toxic. Or paracetamol levels if available. If the levels are above the treatment threshold, again, we consider it as potentially toxic. And the elevation of ALT may or may not be seen early. However, they are seen later. So they are useful as late markers of liver injury. And activity charcoal is recommended for paracetamol within 2 hours for immediate release preparations, or if the preparation is a modified release, then it can be administered effectively up to 4 hours following ingestion. And the antidote we administer is N-acetylcysteine. And the treatment endpoints are INR less than 2 and ALT less than 50 and serum paracetamol level less than 10. So this is the normogram, Rumark-Matthew normogram we used in cases where the paracetamol levels are available. So I'll just briefly talk about these pathways. So this is about a poisoning event with a known time of ingestion following an acute single overdose. So what you can do is, if the child presents within the 4 hours, then you can administer activated charcoal and then do a level at 4 hours post-injection if available. So if your dose is over 200 milligram per kilogram, or if the level is available and if the levels are above treatment threshold, then it's recommended that you start acetylcysteine infusion. So the latest recommendation is that you use 2-bag regime rather than the conventional 3-bag regime, so which is administered as 100 milligram per kilo, 200 milligram per kilo over 4 hours and 100 milligram per kilo over 16 hours. So the total duration would be 20 hours. And towards the end of N-acetylcysteine infusion, you do liver function test, ALT. If it's less than 50, you can safely stop N-acetylcysteine infusion. And if the facility is available, you can do a paracetamol level as well. If it's less than 10, you can safely stop giving N-acetylcysteine. And this is for patients with repeated supratherapeutic paracetamol injections, for example, like erroneous administration by parents. Then the initial management would be the same. However, here you can't use the nomogram. So if your initial dose is over 200 milligram, then you have to give a NAC. And then after 8 hours, you have to redo like liver function test plus, if available, a paracetamol level. And if there are available treatment threshold, for example, if the ALT is more than 50, then you need to continue the whole 20 hours in acetylcysteine infusion. Or if the ALT levels are less than 50 after 8 hours, then you can safely stop in acetylcysteine infusion. And then salicylate, it's another very important poison, which uncouples oxidative phosphorylation and inhibits Krebs cycle, and thereby increases lactic acid production. And this can result in multi-organ failure due to significant metabolic acidosis. And so we managed, because of this pharmacokinetics are deranged and the absorption is quite prolonged in significant poisoning, there is a place for gastric lavage as well as multiple dose activated charcoal in salicylate poisoning. And following absorption, the other methods of management include urine alkalization and hemodialysis. And yellow oleander, because we are running out of time, I'm trying to go a bit faster. So yellow oleander is another common poison seen in the rural areas, and its mechanism of action is the blockage of cardiac sodium potassium ATPase channels, resulting in hyperkalemia as well as various degrees of heart block and fatal cardiac arrhythmias, including ventricular tachycardias. So this is a child with cardiac poisoning and presenting with complete heart block. So these children need to be monitored for a longer period for up to 72 hours, and their electrolytes need to be monitored. And if available, you can do digoxin levels as well, because their absorption is quite erratic, and it might be quite difficult to predict the toxicity. So the treatments include multiple dose activated charcoal and the treatment of hyperkalemia, and then to counteract heart block, you can use agents such as atropine and cardiac pacing, and the more effective treatment is antidigoxin FAP. And then Datura is a plant poison which results in the anticholinergic toxidrome. So you manage that with standard lines of managing anticholinergic toxidrome, which includes activated charcoal and sedation to control agitation, and then cooling, and you can use antidotes in severe poisoning, and the antidote is IV physostigmine. And then castor oil plant, which is the most poisonous plant in our country, which can cause multi-organ failure. Its action is to inhibit protein synthesis, so it results in hemorrhagic gastroenteritis and multi-organ failure. So your management would be supportive and would be aimed at giving supportive care for multiple organ failure. And then kerosene oil poisoning, it's still the most common poison in our households. Most of the poisoning events may be trivial. However, it can lead to breathing difficulties, needing breathing support, and local decontamination. Activated charcoal is generally contraindicated. Steroids and antibiotics may be used, but there is no convincing evidence, so their use need to be decided based on a case-by-case basis. And ethylene glycol is another poison which is used in coolants and antifreeze used in cars. And children can present with drowsiness and CNS toxicity, and you can suspect with the clinical circumstances plus. If you do a blood gas, they will show metabolic acidosis with a very high unexplained anion gap. And activated charcoal is generally contraindicated here, and the antidote of choice is ethanol. But in severe poisoning, you need to consider hemodialysis. And then iron is another poison, like it comes as part of oral contraceptive pills and is one of the common tablets to be ingested by children. It can result in hemorrhagic gastroenteritis and multiple organ failure in severe poisoning with circulatory collapse. So these children might need intensive care from the beginning. As I told, activated charcoal is not effective in iron poisoning. You can try whole bowel irrigation or gastric lavage. And the antidote of choice is IV desferoxamine, which is indicated for children whose blood iron levels are over 3 milligrams per liter. And then tricyclic antidepressants is another significant poison which cause blockage of sodium channels. And also in addition, they are having anticholinergic effects as well as cardiac blocking effects. So it results in various significant manifestations, resulting in life-threatening toxicity. So this ECG shows TCA poisoning. As you can see, it shows the widening of the QRS complexes. So this is a prognostic marker. So if the patient shows QRS prolongation, that indicates the risk of life-threatening cardiac toxicity as well as seizures. So management, because tricyclic antidepressants block sodium channels, your management is to give antidote, which is the sodium bicarbonate, to block to compete with the sodium channel blocking effects of the tricyclic antidepressants, which you can do by giving IV sodium bicarbonate or promoting hyperventilation. And these children can have hypertension due to various reasons, due to alpha-adrenergic blockage and cardiac depression due to direct cardiac blocking properties. So if the inotropes are necessary, no adrenaline is preferable to other inotropes, because the main way of causing hypertension is alpha-adrenergic blockade. And then button batteries are also important poisons seen typically in children. They are found in remote controls, thermometers, watches, calculators, and they can be lodged in upper airways and upper airway or esophagus, which can have deadly consequences. So this needs to be removed urgently. If the button batteries are lodged anywhere above the stomach, they need to be removed urgently. Whereas when you image the child, if the button battery has gone past the stomach, then you can manage through a conservative approach, and then can be just observing without any active intervention. And then there are a few less straightforward presentations. For example, a child or young person presenting with reduced conscious level with no known history of ingestion, or a younger child with altered or agitated behavior with no obvious cause, or young person who ingested recreational drugs. So these are like not very straightforward, but this can be due to poisoning or non-poisoning related event. So these events, clinical toxidromes help in narrowing down the differential causes in circumstances like this. But it's important to remember that we have to rule out other significant medical diagnoses such as septicemia, meningitis, colic crisis, brain hemorrhages, hypothermia, hypoxia when evaluating this group of children. So we'll see what these toxidromes are. So first is called opiate toxidrome. This occurs due to ingestion of agents such as heroin, which can be seen in neonate of a mother who is abusing heroin, or codeine, which is given as a pain relieving agent together with paracetamol. So when you overdose these agents, it can result in opiate toxidrome. And these children typically present with respiratory depression, CNS depression together with a pinpoint pupil. So if you know this triad, then you may try a dose of naloxone to reverse and see whether it's due to opiate toxidrome. And the other group is called somewhat similar, but it's not the same. It's called sedative toxidrome, occurs due to benzodiazepine poisoning. These children also have CNS depression and respiratory depression, but their pupils may be pinpoint or dilated, and also they can have hypotension and bradycardia. And for these children, the management would be supportive care, including ventilation. And then children who present with organophosphate, they present with a toxidrome known as cholinergic toxidrome. So if you have seen these children, they usually present with widespread urination, diaphoresis, diarrhea, bronchuria, vomiting, meiosis, salivation, and paralysis. So if the child is having this constellation of signs and symptoms, then you have to suspect this syndrome and then managed with agents such as atropine, palidoxime, ventilation, and so on. And then the other two are again somewhat similar, sympathomimetic and anticholinergic toxidrome. And what I put in red are the differentiating features of the two. And this group of children, they present quite agitated, usually teenagers after ingestion of either recreational drugs or sometimes they can overdose agents such as promethazine or tricyclics. So they present with anticholinergic. So both groups, they present with hypothermia, like fever, agitation, confusion, tachycardia, hypertension, so look somewhat similar. However, one group, due to sympathomimetic toxidrome, they will have increased sweating and increased bowel sounds, whereas in anticholinergic, they will have hypoactive bowel sounds and a dry red skin. So those two clinical features help differentiating this somewhat clinically similar toxidromes. But your management would be same. So you we have to calm them down using benzodiazepines, and then you can give them hydration. If they're hypothermic, then you have to manage with active cooling. And paracetamol has no effect in these types of children in managing hypothermia. So this diagram again shows in brief, in a illustrative way, how you can differentiate these clinical toxidromes. So what I want to highlight and the practice points we can learn out of this presentation are: the risk assessment is crucial in initial evaluation of any intoxicated child, and that helps us prioritizing and triaging who needs emergent attention versus the children who do not need lengthy management. And then identification of toxidromes helps in arriving at the diagnosis early. And then other medical differential diagnoses also need exclusion in the unconscious child where you have a doubt about the poisoning. And safeguarding is very important. So safeguarding concerns should always be raised in the presence of incompatible history. And children with deliberate self-harm, they do warrant referral to child psychiatry. Thank you very much.